Myself, Dr. JIBRAN, presents to you Simply Pathology, and today we are back with an important session. Today we are going to start with the individual grossing modules, and today we will discuss the grossing of the breast. So I hope you have seen the previous lecture on the grossing, that is the basics of grossing, before starting with the grossing of individual organs. So let us begin today's topic of discussion without wasting any more time. So looking at the relevant anatomy of the breast, so the breast is basically lying in the superficial fascia of the anterior chest wall. So horizontally, if you see, the breast is basically extending from the lateral border of the sternum up till the mid axillary line. Okay, this is the horizontal extension of the breast. Vertically, if you see, they are extending from the second to the sixth rib. Okay, they are extending from the second to the sixth rib vertically. Okay, now if you see, the breast is basically lying on a group of muscles. So what are those muscles? Let me highlight. So you can see over here is the pectoralis major. So it is lying on the pectoralis major. It is lying on the latissimus dorsi over here, and it is lying on the serratus anterior muscles. Okay, so this is forming the bed of the breast. Okay, so let me just repeat whatever I have highlighted. So the breast is lying in the superficial fascia of the anterior chest wall. It is extending from the lateral border of the sternum to the mid axillary line and vertically extending from the second to the sixth rib. It is lying on the following muscles, that is the pectoralis major, latissimus dorsi and the serratus anterior. Now if you see, the breast can also be divided into anatomical gradients. So there are four gradients, as you know. So there is the upper inner gradient, okay, there is the lower inner gradient, upper outer gradient and lower outer gradient. Now if you see the upper outer gradient, it is basically extending and forming something called as the tail of Spence or the axillary tail. Now this tail of Spence or the axillary tail, it is actually continuing along the inferolateral border of the pectoralis major muscle, okay, and it is entering the hiatus of Langer into the deep fascia of the medial axillary wall. Now discussing the lymphatic drainage of the breast. So what are the important groups of lymph node? The first very important group of lymph node is the axillary group of lymph nodes, which is divided into three levels, level 1, 2 and 3. So those group of lymph nodes which are lying lateral to the lateral border of the P minor, they are, okay, level 1 lymph node. Okay, then there are level 2 which is lying under the pectoralis minor muscle. Also the interpectoral lymph node, that is the rotus lymph node, they are also constituting the level 2 axillary group of lymph nodes. And lastly, we are having the third group which is lying medial to the medial border of the P minor, which is forming the level 3 axillary group of lymph nodes. So let me illustrate with the help of the diagram. So everyone can see this is the pectoralis minor muscle. So lateral, so this is the lateral border. So lateral to the lateral border, we are having the level 1 axillary group of lymph nodes. Now just beneath, along with that, just beneath, okay, the P minor, and along with that the interpectoral rotor node, these two together they are constituting the axillary lymph node level 2. Okay, and then we are having certain group of lymph nodes which are lying along the medial border. So just medial to the medial border of the P minor, we are having some group of lymph nodes which are constituting level 3 axillary group of lymph nodes. Okay, apart from that, we are having other group of lymph nodes as well, like the internal mammary group of lymph nodes, supraclavicular group of lymph node. Then there are certain intramammary group of lymph nodes, infraclavicular group of lymph nodes are also there. Okay, so why am I talking about them? Because for the staging of the breast cancer, these forms an important component. Okay. So basically we have spoken and we have seen about the axillary group of lymph nodes. What are the other groups? As I already mentioned, internal mammary, supraclavicular group of lymph nodes and infraclavicular nodes. Then we are having intramammary nodes which are mostly found in the upper outer quadrant. Okay, so this is about the lymphatic drainage. Now having spoken about the lymphatic drainage of the breast, I would like to discuss the PN staging. Okay, the PN staging. We all know that there is TNM staging, right? We are having the tumor, we are having the node and we are having metastasis. Okay, so over here, because we have discussed about the lymph nodes, so I will be discussing about the PN staging according to the AJCC 8th edition. So NX means when the regional lymph node cannot be assessed. N0 means no regional lymph node metastasis identified, or ITCs only, that is you have isolated tumor cell cluster only. PN0 again can have two types. One is I plus. What is I plus? It means ITCs are present only, which is no larger than 0.2 millimeters. Okay, so malignant cell clusters are present, okay, but it is not more than 0.2 millimeters in maximum dimension. Then it is MOL plus. Molecular plus means you have positive molecular findings by RT-PCR, but no ITCs are detected. So always remember PN0 means no regional lymph node metastasis identified, so or only ITCs. Again, when the ITCs are there, it can be I plus if it is not larger than 0.2 millimeters, and mol plus if only positive findings are there by RT-PCR but no ITC is detected. Then we are having PN1MI. MI stands for micrometastasis, which is equivalent to approximately 200 cells larger than 0.2 millimeter but none larger than 2 millimeter. Okay, very important. So I plus, it should be less than 0.2 millimeter. Okay, micrometastasis should be more than 0.2 mm up to 2 millimeter. Okay, that is micrometastasis. Now coming over here, the staging continued. We have PN1 staging, PN2 staging, we have PN3 staging. So pay a lot of attention over here. What is N1? So N1 can be N1A, N1B, N1C. So whenever there is metastasis in 1, 2, 3 axillary group of lymph nodes, and at least one metastasis which is larger than 2 millimeter, that is the criteria or the requirement to place it under the N1 category. Okay, and at least one metastasis is larger than 2 millimeter. Now if along with that 1B, when do we call it as 1B? When there is metastasis in the ipsilateral, that is the same sided internal mammary sentinel nodes, okay, then we call it as PN1B. And if N1A and N1B, both of them are present together, then we call it as N1C. So N1A is metastasis in 1 to 3 axillary lymph nodes and at least one metastasis measuring more than 2 mm. 1B is metastasis in ipsilateral internal mammary lymph nodes, and both 1A and 1B together they are forming 1C. Okay, so remember N1A, N1B, N1C. Then we are having PN2A. What is N2A? When there is metastasis in 4 to 9 axillary group of lymph nodes, at least one tumor deposit measuring more than 2 millimeter. What is 2B? 2B is metastasis in clinically detected. Now over here is in ipsilateral internal mammary, but it is pathologically detected. But if it is clinically detected, for example, by radiological investigation or by clinical examination, so metastasis in clinically detected internal mammary lymph node with or without microscopic confirmation with pathologically negative axillary lymph nodes, okay, this is basically called as PN2B. So when clinically in the internal mammary nodes you have detected metastasis, but pathologically you have not found any such metastasis in the axillary lymph node, then you are using PN2B. Okay, so it's very clear what is 2A and 2B. Then we are having 3A, 3B, 3C. So metastasis in 10 or more axillary lymph nodes, at least one tumor deposit larger than 2 millimeter, or metastasis to the infraclavicular group of lymph node, that is the level 3 axillary lymph nodes. Okay, what is 3B? 3B is nothing but PN1A or PN2A, 1A or 2A in presence of N2B, that is positive internal mammary nodes by imaging. So if there is a positive internal mammary nodes by imaging, CN2B, that is clinical staging, in presence of PN1A or PN2A, if there is 2B, then we call it as 3B. This is one. Other is, or if there is PN2A in presence of PN1B, that is also equivalent to N3B. And what is N3C? Metastasis in the same sided ipsilateral supraclavicular group of lymph nodes is constituting N3C. Now this is important. Remember, in the grossing viva, this N staging can be asked at least for the major important gross specimens like the breast, for the colon, etc. Okay, now we are going to see some of the grossing pearls. Okay, that is how you can identify or how you can make a diagnosis of a breast carcinoma, specific breast carcinoma, just looking at the gross findings, or any other benign lesions also you can understand looking at the gross findings. Now we are going to understand about the grossing of the breast, the main core grossing of the breast. So what is the rationale? You have to document the tumor size correctly, because the T staging is dependent on that, whether all the relevant margins are free of the tumor. So you have to take the samples from the margin very nicely, okay, because you have to document the margins, okay, because you have to establish whether the surgery was clean or not. Then we have to have a proper preservation of the tumor. So for that, proper fixation is very important. Why? To maintain the antigenicity, to maintain the antigens, because later on we have to carry out the ER, PR, HER2 neu, because this is important for therapeutic purpose as well as they have prognostic implications. So you don't want to ruin that particular tissue sample. So proper fixation is very important. So what are the different kinds of gross specimens that you will receive in relation to the breast? So we can either have the biopsies, we can have the lumpectomies, we can have the mastectomies, then we can have mammolocalization excision, and we can have microdocectomy specimen. So very importantly, in the specimens, the biopsies, it can include the TRUCUT biopsy. I will show you what a TRUCUT biopsy looks like. Then there can be an incisional biopsy. Incisional biopsy means, for example, if this is the breast and this is the tumor, incisional means that a portion of the particular tumor is removed only. That is what is an incisional biopsy. Now, for example, excisional biopsy means if the entire tumor mass is removed along with some area of normal breast tissue as well, then that is called as an excisional biopsy, and this holds true for all the tumors arising in any part of the body. So there is a TRUCUT biopsy that we can get from the breast. There is an incisional biopsy wherein the lesions are removed partially. There is an excisional biopsy wherein the lesions are removed completely with a rim of surrounding normal tissue, and this is synonymous with lumpectomy. This is synonymous with lumpectomy. So excisional biopsy of the breast and lumpectomy, they are the same things. Okay. Then in case of breast, we have the mastectomy, that is the removal of the breast. Now there are different kinds of mastectomy. So remember the main point that I am telling you. We are having an MRM, that is a modified radical mastectomy, the most commonly received specimens in our laboratory or in our histopathology lab. So MRM में क्या होता है that the pectorals are preserved. In radical mastectomy, the pectorals are removed. In simple mastectomy, the axillary tail, lymph nodes along with the fat is also preserved. In subcutaneous mastectomy, the overlying skin and the nipple are also preserved. In quadrantectomy, as you know, there are different quadrants, anatomical quadrants. So over here, the portion of the breast corresponding to the anatomical quadrant is removed along with the axillary contents. Then we are having supra-radical mastectomy, wherein this is radical mastectomy plus a resected segment of the chest wall. Then it is called as a supra-radical mastectomy. The other kinds of or categories of specimen that we are having is a mammolocalization specimen and microdocectomy specimen. So mammolocalization is when lumpectomy is done for lesions which are detected radiologically, which are localized mammographically. Microdocectomy is excision of the nipple ducts. Okay, the nipple ducts with a cutoff surrounding breast parenchyma, usually done for intraductal papillomas as well as for DCIs, that is ductal carcinoma in situ. So whenever the process is involving a duct, so along with the duct, okay, the surrounding normal breast tissue is also removed. Okay, that is called as microdocectomy, mainly done for intraductal papillomas and for DCIS. Now, what is the prerequisites for grossing? So for transport, so rapid fixation is required. So the volume of fixative should be at least twice that of the specimen. Now remember, this is the least amount of volume and this is the volume of fixative which is required during the transport. Okay, not during the fixation. It is during the transport of the breast. Then the sample acquisition, proper checking, identification, orientation, patient particulars, all these things we have discussed under the basics. So you have to do that. I am not going to the details of that. The specimen orientation in case of breast, it is very important. So remember, the short suture is always reflecting the superior aspect of the specimen. The medium suture is reflecting the medial aspect. The long suture, the lateral aspect of the specimen, just like this. So over here we can see, this seems to be a lumpectomy specimen. An excisional biopsy from the breast, the entire tumor along with the normal parenchyma is removed. So over here the short suture is reflecting the superior portion. The medium suture is reflecting the medial portion, and the long suture is reflecting the lateral portion. Okay, so this is how you orient. So orientation is again very important. Now, very importantly, now in case of lumpectomy, this is one way of highlighting, that is by using sutures. Another way is that, so whatever surface is there, where there be the superior surface, you give one color. Okay, inferior surface is there, you use another color. Lateral surface is there, you use another color. Medial surface, you use another color. Okay, anterior you use one color, posterior you use one other color posteriorly. Now this color coding, it is quite variable, highly variable, and it is varying from institute to institute. So every institute might have their own protocol to ink different margins or different surfaces. So in general, a standard that is followed in our country for superior, this is not matching or conforming to this. So in our country, the superior surface is marked blue, inferior green, medial can be brown or orange, lateral is yellow, superficial is red, and deep surface or the circumferential, the deep margin is mid black in color. Okay, so I hope this is clear to everyone. Now, the next prerequisites include you should weigh the specimens ideally and you should measure them ideally. Okay. Now, what is the importance? What all things you should do in the fresh versus the fixed specimen? Now, it is always said that if you take the measurements, okay, the measurements should always be taken in the fresh state. Okay, even the tumor should be taken in the fresh state. Even basically the measurements and the depth of the tumor should ideally be taken in the fresh sample. But remember, there are certain differences. Remember, fresh specimen gives a better gross and better feel, but for laboratory safety, the personal grossing should be done after fixation. So for the safety of the lab personnel, we should do it after fixation. Why? There are two things. Now, when the particular specimen is not fixed, means the microorganisms are alive. So if you have a cut, so from there the microorganisms can enter your body. First thing. Second thing is that any specimen which has not been fixed, so if you take in your hand, especially the breast tissues, they are very slippery, okay, and they are very soft. So unless and until there is a fixation, you cannot properly cut, okay, and you cannot properly do the gross examination. So this is very important, okay. So that is why most of the grossing is done after fixation. Again, the breast tissue specimen must be fixed in 10% neutral buffered formalin for no less than 6 hours and not more than 72 hours, and it should be done in 10 times the size, 10 times the volume of the specimen. So the amount of formalin that is used is at least 10 times, okay, that you should use. Then inking, slicing the specimen, okay, cutting in between the slices serially, measuring the tumor size, margins and overnight fixation. So what is very important, that inking is very important. Now inking, usually whole inking is not done in our institutes in India at least, but in abroad, in other countries, they usually tend to ink the entire surfaces, so for easy orientation. So for example, if this is the breast MRM specimen that you have received, and suppose there is an axillary tail also. So what they are saying that you should cut in several intervals. This is called as a pre-grossing. Like this you should cut, okay, you should cut like this. Not completely, okay, from the base they will be joined, but from the DRM or from the distal resection margin you should cut. So completely from the deep margin, okay, from the deep margin you should start cutting, or the DRM you should start giving slices, serial slices like this. Now for example, the tumor is basically present in this location, for example I am telling you. So what will happen, that from the side when you look, you have to see, or you have to select that section wherein the tumor is going maximally or is closest to the DRM. This is the deep resection margin. From here only you have started cutting, okay. Now you have to select that. For example, over here, this is the particular section. This is the particular section wherein you can see that the tumor is going and it is very close to the distal resection margin. It is very close to the DRM. Okay, so you should take that section and then you should do the measurement. So you should take all the the anterior posterior measurement, okay, the medial lateral measurement, okay, and the depth. So the length, breadth and the depth, okay, is very important, and what is the distance from the DRM, or how close it is to the DRM, it is very, very important, okay, how much distance it is close to the DRM. So this becomes again very, very important, because if the DRM is involved, that means your surgery is not complete. What is the distal resection margin? For example, this is the breast, so completely the deep, okay, the posteriorly the margin that is there, that is forming the DRM over here, okay, so that is very important. And in between the slices you should place the cotton wads which are soaked in formalin. Why? Because those cotton wads which are basically kept in between, they will allow the formalin to penetrate for better fixation. This is very, very important. Okay. So these are the prerequisites. So the prerequisites are the same for all the different types of the specimen. Now we are going to discuss the grossing of individual types, starting with the TRUCUT biopsy. So I told you that I will tell you what a TRUCUT biopsy looks like. So I have already shown you about the TRUCUT biopsies, how they look like in the basics of grossing. So this is how, if there is a tumor of the breast or swelling of the breast, so with help of the TRUCUT biopsy needle, you are going to introduce like this, okay, and you will take a gun, you will take a core. Now if you see, the core looks like this usually, okay, like this. So you can see over here the core. This is the TRUCUT biopsy. In any organ it will look like the same. So TRUCUT biopsies are very small linear bits of tissue. You should document how many such cores are there. So document the number as well as the size, that what is the length, maximum dimension, what is the length, measure the length. Okay, then you should place them in the filter paper like this, and you should blot it with the eosin. So you should eosin mark and embed it completely, and then you should fold, and then you should place it in the tissue cassette. Now this was for this is how you process or do the grossing of the TRUCUT biopsies of the breast. Okay, coming to the lumpectomy specimens. Okay, just for example, they have not sent, this is the breast. So this is the basically this is the lesion. So they have just taken this part, for example, for fibroadenoma, or for example any lesion along with the swelling. They have also taken some amount of the normal breast tissue has been taken as well. This is the lumpectomy or the excisional biopsy of the breast. So how do you do the grossing for the excisional biopsy? So you should confirm the size. Okay, you should orient it nicely. What is the orientation? We have already spoken about that. If you can, you should draw. Drawing diagrams give a better orientation. I have already spoken about that. Then you can ink the surface. Okay, in our country they do not ink the entire, only the margins are inked in our country, but in other countries, in foreign countries, they tend to ink the entire, you know, superior, inferior, medial, lateral, anterior, posterior, all the surfaces are inked. Now the rule is, first you should dab with alcohol, then you should apply ink, because in this case then the ink becomes, you know, very nicely fixed on the surface. So how do you slice? So how do you gross such you know, lumpectomy specimens? So there are many ways. So there is a sagittal slicing. Sagittal means when you are slicing, so if this is the particular specimen and this is medial to lateral, so you keep on slicing serially like this, that is sagittal sectioning. I will show you. Then there is coronal. Now if the specimen is like this long, so you can you know, slice it from superior to deep. So superior to deep or anterior to posterior. So you can do the coronal section like this. Okay, it is like this vertically, that you are going up to down. So it is anterior or superficial, posterior or deep, like this you can carry out. This is the coronal section. Now basically this sagittal sectioning or slicing is done for those specimens which are less than 3 centimeter. Less than equal to 3 centimeter, you do this sagittal, means the entire specimen is completely, it is given for the tissue processing. But if the specimen is very large, it is more than 3 centimeters in size, we go for en bloc method, wherein only we do a selective grossing, because we cannot take so many sections. Okay, else it will become very difficult. And then we also have the crucial slicing or the radial block method for large palpable mass or a visible abnormality. Okay, so we will discuss each one of these most important points. So let me show you the number one method. As I showed you, this is the sagittal slicing. This is for lumpectomies less than equal to 3 centimeters in maximum dimension. So this is how the specimen is there, and this is how they are oriented: short superior, medium medial, long lateral. Okay, so there is a serial slicing over here. As you can see that this is 1, 2, 3, 4, 5, 6. So all these are serially sliced and then they are wholly embedded and they are given for tissue process. This is the sagittal medial to lateral slicing. Then this is the coronal, as I told you, anterior or superficial to posterior or deep, as you can appreciate over here how they are going from here, and completely the specimen is given. Again, this is done for slicing the microductectomy specimen, because the ducts are dilated and they are oriented in an anterior to posterior or superficial to deep orientation is there. So for microductectomy specimens which are less than 3 centimeters, you are going for this coronal slicing like this. And as I told you, for larger specimens, lumpectomy specimens measuring more than 3 centimeters in diameter, you go for the en bloc method. Now what do you do in en bloc method? You cannot take everything. So what you have done over here, this is such a big specimen, so we cannot take everything. So what we do, there is the medial margin, there is a lateral margin over here. So what we will do, we will cut these margins like this, and then these margins, they are individually cut in this fashion. They are individually cut in this fashion. So they have been inked already and they are individually cut in this particular fashion, and then they are submitted. So the medial margin and lateral margin, they are submitted in the exact same way that you have seen. Then for example, you see that for this considerable length up till these two areas, you cannot see any tumor. Everything is all right. Starting from this quadrant, 1, 2, 3, 4, 5, 6, 1, 2, 3, 4, 5, 6, you get different sections. Okay. So what you do, you have basically sliced everything like this, okay, till this point, okay, and you have also gone one perpendicular line like this has also been sliced. So what you do, these individual segments you are submitting, like for example, you label them B, you label this section as C, you label them D, you label this as E, you label them F, G, then you label this as H, you label this as I, you label this as J, then you label this as the K. Okay, so these specimens involving this portion L and this M. Okay, so from B to L over here and from C to M over here, they are individually, they are submitted. Okay, so from this area you can see that you start seeing the tumor. So you are just, you are just only processing those areas which are having the tumor, and this is called as the en bloc method. You will not ask to demonstrate, but you should just know, just for explanation, I have explained this in details to you, what is en bloc method of dissection. Okay, so I hope this is very clear. Now the other steps, what are the other steps that we have to do? Sampling and measurement of the margins. So as I already explained, there are two types of margins. One is the shave margin, one is the radial margin. So if you have not seen what is the meaning of shave margin and radial margin, please go back to the lecture on the basics of the grossing. There you will understand what is the meaning of a shave and what is the radial margin. So basically the shave margin, remember the margin, this is taken when the margin is very far from the tumor. So for example, if you see over here, if the margin is over here we will just take a shave. If this is the tumor, okay, so we will just take a shave from here because it is very far. So in that case, we take a shave margin when the margin is very far from the tumor. You should always embed the shave margin in a way that the ink side is first sectioned. Okay, the ink side should face the microtome for sectioning first. Okay, so for example, this is the tumor and you have taken margin like that and you have inked this portion. So this portion should come under the microtome first. Then there is a radial margin. Now suppose the tumor is very big and it is very close to this margin. Radial margin is taken when the margin is very close, so you can take a perpendicular section like this. So you can measure the distance between the tumor and the margin like this over here, and this is called as basically the radial margin when it is very close. So you take a section like this. So one part over here, for example, this part, if you can see, this part is basically the tumor and this is basically the distance between the tumor and this is basically your margin. Okay, this is the radial margin wherein the tumor and the margin are in the same section. So when it is possible to have the tumor and the margin in one section, okay, and this happens when the distance is less than 2 centimeters. So in 2 centimeter, it is in 2 centimeter gap only you are having both of them. So the order of taking margin is SIMLAB, superior, inferior, medial, lateral, anterior, posterior. This is the order of taking the margin if someone asks you. Now the tumor evaluation and the sectioning of the tumor proper. So how do you do that? The tumor size is important for staging and for adjuvant therapy. You should measure the largest dimension of the tumor. Okay, so if this is the tumor, this is the largest dimension you should measure. Samples which are less than 3 centimeter, they should be submitted in entirety. As I have shown you over here, the first two ways, sagittal sectioning and coronal slicing, as I told you, these are less than 3 centimeters and they should be submitted completely or entirely. As long as there is a distinct volume of normal breast tissue between the two nodules and both can be measured independently, the sample is having two tumors. So for example, you have this particular breast tissue. And for example, there are two particular tumors over here, and if they are not connected with each other, then we will call it as two individual tumors. Remember one thing, that post chemotherapy scarring or fibrosis or extensive DCIS in adjacent breast can falsely assess large tumor size grossly. You should always take the history whether any chemotherapy was received by the patient or no, because for example, after chemotherapy maybe the tumor size is this much, but this much you can see scarring. So you should not by mistake take the size of tumor as this much. The size of tumor remains to be like this. This is very, very important to understand. Now over here again, I have just repeated what is the shave margin and what is the radial margin. So when the particular tumor is very far from the margin, so we take a shave margin just like this, as we can appreciate over here. This is called as a shave or end face margin. This portion is inked and the inked part should always be embedded in such a way that when you are taking the sections, that should face first. Okay, because if the tumor is present, okay, it should be detected from the most outer portion to the inner portion. Okay, why this is important? That suppose for example, if this you have taken, this is, if for example you take a very thick shave margin like this, and for example some amount of tumor is come over here, and for example this part was inked, but you have embedded in such a way that this portion is sectioned from this portion. So what is going to happen, that because this portion was sectioned first, so the tumor came over here first. As a result, what will happen, it will become false positive. That is why the shave margin should be very thin. Now if the margin and the distance between the margin and the tumor is it's very close to each other, then in that case, in the same section like over here, the radial or the perpendicular margin is taken. So over here you can see the tumor has come, you can see some distance between the tumor and this has come, and the margin has also come over here. Okay, so this is possible when this entire margin is up to 2 centimeters in length. So this is the basic shave margin as we can appreciate, and this is the basic radial margin as you can appreciate. This is true for any tumor. Okay. Now the lymph node evaluation. We are yet in the grossing, the special steps for the lumpectomy specimen. So axillary tissue is usually sent separately. Always remember, lymph nodes more than 5 mm is to be sliced to detect any small metastatic deposit. Lymph nodes which are less than 5 mm should be submitted entirely. Okay. Accurate assessment of the number of positive lymph node, as we have already seen, it is helping in the N1, N2, N3, PN1, N2, N3 staging. Okay, that is the pathological staging, as we have already seen. Okay, it is helping in the staging, so it is very important and an important critical prognostic marker. Sentinel lymph node should be sliced at 2 mm intervals and should be submitted in entirety. Now, what are the sections that you should give in case of a lumpectomy? So minimum 4 sections of the tumor, and not only the tumor, along with that you should give an adjacent breast tissue as well, because always remember, if this is the tumor, this is the entire breast, this is the tumor. Okay, so always along with this you should give one section like this, 4 sections like this you should give, and you should always sample the nearby normal looking areas, because maybe the intraductal component or the precursor component, for example DCIs, if it is present in the nearby portions, it is very much, it is basically proof that the tumor has arisen in this particular tissue only. Okay, so to document the intraductal component and the lymphovascular emboli, plus normal breast is also serving as an internal control for hormone receptor evaluation in case we are carrying out the immunohistochemistry. So if we are taking the normal breast, then they can serve as a control. Okay, so we can use it as a control to see whether the staining is proper or no. If the nipple or any skin is also included, then that should be given. The margins, as I have already discussed, superior, all the different margins, SIMLAP, it can either be shave margin or, and wherever it appropriate, you have to give the radial margin as well. If nodes are sent, then you have to submit the nodes also in the way that we have discussed right now. Okay, so this is basically about the grossing of the lumpectomy specimen, and now most importantly, we are going to see the grossing of the mastectomy specimen. Most commonly we receive the MRM specimen. Okay, and most commonly this is kept in your exams for your grossing purpose. So let us look at the grossing of the mastectomy specimen. So this is how a mastectomy specimen is there. Now